just to give a little bit of background to this, whilst in many countries there is a lot that can be done to help people with Prader-Willi syndrome through ensuring an early diagnosis, providing guidance and support, and so on. The only formal medical treatment in terms of medication, if you like, is growth hormone. And that's been approved for over 20 years in many parts of the world, primarily for children. And the reason it's given to children is an obvious one, is that it helps growth. It's less commonly approved and given to adults with Prader-Willi syndrome, although a strong case can be made for that. And the background to this study is that I think IPSO has been aware for some time that there are real global inequalities in terms of access to treatment, specifically to growth hormone, as well as wider inequalities in terms of early diagnosis and so on. And I think we are aware as an organization that we really didn't know very much exactly the extent of the issue. To what extent did countries have systems of gaining approval for such things as growth hormone, in this case for a rare disorder? How available was medication, in this case again growth hormone, and how affordable it was. So really, this is something that's been in planning for some time, but we decided the time had come to really look at this in more detail. So the aim of this particular study was to establish the extent to which globally growth hormone has been approved for children and adults with Prader-Willi syndrome, and whether or not it is available and affordable. I think we should probably have accessible as well in there as well. I want to stress that this is a presentation of very preliminary findings. Joyce Whittington has led on the analysis and has worked very hard at this, but it's still relatively early days. And for those of you who engage in research, you'll be aware that always things are never quite as straightforward as you think they're going to be. And it's been sort of quite hard work to really make sense of the data that we have. So what I've done is pull out what I hope are a few key data points and messages that will help shape any discussion. And I think these will fit rather nicely with your talk, Alexander. So just to give you the background in terms of how we went about the study, this was an internet-based survey. So the first stage was really to develop the survey. And I led on this, but this was then passed around to a number of people for guidance and further development. We piloted the draft survey with some parents and with a medical professional, made some various changes as a result of that. And then we set about approaching our contacts in different parts of the world. What we were keen to do was to try and have both a medical professional and a parent in as many countries as we could encourage to take part as possible. So much of the data is about individual countries, although the participants are about our parents or a medical professional from that country. We were keen to do this because we wanted, if you like, the two perspectives, what was thought to be the case and what in reality was the case. So, and in each case, we asked the people we chose where this was possible and who agreed to help us with this, we asked them to consider the wider national circumstance. So they weren't talking about, in the case of a parent, their experience with their particular son or daughter. We wanted them to think more widely than that in their knowledge of other people and other families with a child with Prader-Willi syndrome. What was the general experience in that country? So many of the parent responders were, for example, involved with national associations or parts of larger groups. So they did have access to other people's experience about this. We're always aware of the issue of language. So we made the survey available in English, Spanish, Arabic, and French. The completed surveys that then were returned to Shelley at IPSO, and anonymized completed questionnaires were then sent to Joyce Whittington for further analysis. We also felt it was important as part of this survey to get some sort of context. So we asked some fairly limited information about Prader-Willi syndrome in general in that particular country. So, how well was it recognized? How easy was it to get a diagnosis, and so on. And also asked a little bit about local services. Who could they turn to for guidance and support, and so on. And then we also afterwards, once we knew which countries had taken part, we looked at the national economic status of those particular countries, population size, and a few other factors. And I'm going to just mention that again in a few moments. But we sort of hypothesized from the beginning that we would anticipate that for the countries with lower socioeconomic status, then you might anticipate much greater problems getting access to growth hormone as well as access to treatment. So I'm just going to, sorry, there's just something obstructing my screen here. I'm just going to move. The number of countries that took part, we had 127 respondents from 80 countries. So you can see that we didn't have 2 respondents from every country. And I'm not going to go into that detail, exactly which countries had 2 respondents and so on at this stage. But this is going to be important when we look in more detail at differences between what parents said and what professionals said. Then we had 39 countries who were of high socioeconomic status, and I've given, as you'll see next to that, the range in populations. And you can see the range is enormous. And we took the decision, by the way, not to name individual countries because we were concerned in some countries that might mean that the parent or the professional who had given us the information could be identified, and that might lead to problems. But you can anticipate some of these countries just simply on the population size. So the only group really that we didn't have many countries representing was those countries of low socioeconomic status. We had a reasonable representation from the other 3 groups. So that I think was encouraging. So now to look at what we found. So this shows that the first question we asked ourselves was, do all countries have an approval system in place for approving not just growth hormone, for any medication? And we were interested in this because we were interested in ultimately where might IPSO influence? Where should we attempt to influence a change in policy in a country where growth hormone isn't available? Or what advice might we give to a parent or a professional in any country about how they might get growth hormone approved? And you can see by and large, and the numbers, of course, in the low group, just 4 here, in the low socioeconomic group are small, and it's difficult to draw many conclusions from the percentages there. But by and large, the countries had a system of approval in place. Interestingly, in the high economic group, there were 3 countries that said they had no system in place for approving new medications. So having looked at that, we then asked ourselves, we asked about, in your country, was growth hormone approved for a child with Prader-Willi syndrome or child and adult with Prader-Willi syndrome? And here you can see, again, in the high economic group, what you find is that over half of it's approved for children. And if you take children and adult as well, over it must be 70+%. It's 80+%. It's approved for a child. And I think the child adult group, it will always be approved for children as well as adults. And therefore, I think we can say that there's a very high percentage approved for children, but less so for adults. The number drops off as you move across the groups. There is an interesting group here, that's no Prader-Willi syndrome, no PWS. And they're countries in which growth hormone use is approved, but not specifically for Prader-Willi syndrome. Or it may even be a contraindication. So it's approved for children who have growth hormone deficiency, but Prader-Willi syndrome doesn't seem to be included in that. And that's an oddity for us, and we need to look at this in greater detail. So at one level here, there are some positive features, certainly in countries of high socioeconomic status, less so in medium and medium high and medium low. And it does tend to be concentrated around children. We then asked about use, and the way we did this is we asked people to come to an opinion about whether in their country, in children, for example, it was being most are using it, about half, most are not using it, or none are using it. And you can see here, this is very much really more concentrated in those countries that have high socioeconomic status, the 38. Now, I should say that the numbers in each group slightly vary over time because not everyone answered every question here. So that's the explanation for that. But you can see that in the high socioeconomic group, a fairly high percentage are being either all in these countries, either all are using it, all children are using it, or most children are using it. But it's not universally being used in all these countries. In the medium group, then the numbers drop off, and you see there that as far as our informants in those countries were concerned, there were no countries there in which all children with Prader-Willi syndrome are likely to be using growth hormone, and only just over a quarter are they in those countries. Is it likely that just over a quarter of children are using growth hormone? So as I say at the bottom of the slide, there's extensive use of growth hormone treatment in children with Prader-Willi syndrome, but that is dependent, we think, on socioeconomic status of the countries, which I don't think is surprising, but I think it's a necessary observation to make to confirm that that is the case. Here we looked at adults, and here really the picture is rather different. So regardless of the socioeconomic status of the country, less than 50%, and in some cases it's much more marked than that, less than 50% of adults with Prader-Willi syndrome are estimated or judged by the informants, or less than 50% of adults in these countries are judged to be receiving growth hormone. Again, that's perhaps not surprising because growth hormone, people think of growth hormones primarily to improve growth. And of course, it has to be given to childhood for that. But there is good evidence, as the endocrinologists will know, to suggest that it continues to bring benefit to adults with Prader-Willi syndrome. And IPSO has put out a formal statement believing that it should be given to adults with the syndrome. We also had received anecdotal reports that it might be available in the country, but it was available only in some parts of the country, such as in urban areas rather than rural areas and so on. And you can see here that even in countries of high socioeconomic status, it was generally broadly available. But when you move into the different groups of countries, there you find increasingly it's only available in some parts of the country. And that would suggest to us that there are some people who would have children, some families with children with Prader-Willi syndrome who'd wish for their child to be on growth hormone, but it wasn't available or accessible to them because they lived away maybe from a major population center or the country's capital. And this is something that we want to investigate in a little more detail. Now, obviously, key, and Alexander, you hinted at this with the two examples you gave. A key to this is that you're never going to get growth hormone unless a diagnosis is made, because only when the diagnosis is made is the case for growth hormone, can the case for growth hormone be made. And here again, the sort of anecdotal stories we heard that, again, if you live in the capital, you might well get a diagnosis, but in other parts of the country, you may not get a diagnosis. It requires a pediatrician or a nurse or someone to suspect the condition in the first place, and then to seek further guidance and to seek genetic testing. And you can see here that it's certainly in the medium-high, the countries of medium-high socioeconomic status, 63% said there's only in 63% of those countries was it available only in certain centres. So that I think is of some concern. And this, I'm sure, what is very common across other rare disorders, both in terms of getting the diagnosis and then, if you do get the diagnosis, having access to treatment. We were also interested in who could who could prescribe growth hormone. And here we have divided in terms of whether there was an agreement between the parent and the professional, where we had both answers from both in any given country, or whether there was a single response, just one person from that country. But you can see by and large, it was said that an endocrinologist was required in order for growth hormone to be prescribed. And that again raises issues because in some countries there may not be ready access to someone with that particular expertise. As those of you who are endocrinologists will appreciate, there is in some places, in some countries, it's necessary to show evidence of growth hormone deficiency in order to prescribe growth hormone, and that the diagnosis of Prader-Willi syndrome in its own right is insufficient. Here, there was by and large not bad agreement between professionals and families about this, but in quite a high number of countries, the diagnosis of Prader-Willi syndrome is sufficient in itself. But in some countries, it was necessary to get lab evidence of growth hormone deficiencies. So practice, and this was the comments from a more qualitative part. People were asked to make comments at the end of the survey. These were some of the comments: that practice varies across countries, clinicians are ignorant about Prader-Willi syndrome, and one person commented about there were differences between what were seen as the official condition, the official rules, and the actual experience in practice. So if someone happened to know the doctor, then you could get the growth hormone provided without having to go through getting evidence for growth hormone deficiency. We were interested in who pays for growth hormone. And here, I think what you find, if you look at this column here, that in this case, it's reported, these are parents reporting this, I think, by and large, that in a significant number of countries, it was families that have to pay. And what people commented was that there were different funding systems that might operate even in the same country. To some extent, it may depend on the age of the person with Prader-Willi syndrome, parental employment or family income. So there were there were 31 countries in which it was free from the health service, a small number of countries where it was subsidized. But there were certainly countries in which the family had to pay, and that was a cause for concern. There was a question about sleep studies, and in many countries, many of the respondents said yes, that sleep studies had to be undertaken. Again, this raises issues because people need to have access to having sleep studies undertaken and may have to cover the costs of that. And I want to end really with just some comments from the more qualitative part of the survey. So parents, particularly I think parents, were saying diagnostic methods are not available. I should say that IPSO does provide a diagnostic service. If people, we can receive or arrange for blood spot to be sent to a laboratory in Italy for diagnosis. But though clearly this remained an issue, that there were not enough doctors aware of the syndrome. So again, that would hinder diagnosis and therefore growth hormone wouldn't be given. That sometimes they just simply said, well, the child had an intellectual disability, or in other cases, the child had cerebral palsy. So one never moved beyond that to say, well, growth hormone might be beneficial to that child. These are comments about whether it's available or not. It's unavailable, overpriced, only given to some who are diagnosed as having a growth hormone deficiency. Availability was described as random and expensive. And then another, that people, is not available in the country, but those who have the money and have the contacts may bring it in from outside their country. And in terms of costs. It may be available for children with Prader-Willi syndrome and paid for by them, but adults had to pay. The price was described as exorbitant in some cases, and it was only reimbursed in some cases for children. And so when a child became an adult, they no longer received funding to continue on growth hormone and would invariably have to stop. Now, as I said at the beginning, I want to emphasize that further detailed analysis needs to be undertaken here. Some of the figures may change as we look at it in more detail, but I think there are subtleties there that need to be teased out. I think we can say that growth hormone treatment for children was not bad, but it was far less available for adults. Some countries, growth hormone was approved, but not for people with Prader-Willi syndrome. Barriers included lack of diagnosis of Prader-Willi syndrome, limited professional experience, and variations in availability, accessibility, and affordability. And Alexander, you may be able to advise more about this, but we know that the WHO have a list of essential medicines that they believe that every country should carry and make available free to their population. And this is the quote taken from the document about WHO essential medicines lists for children. And one of the issues I think for us IPSO as a charity and as a global organization is really to find the levers that we can use to make changes about this, and whether those levers are at national level or, if you like, through international organizations such as a WHO is perhaps beyond our expertise at the moment. But this is the sort of thing that we hope this survey will sort of help us think about more, is how do we bring about change in those countries where growth hormone isn't readily available. So I'd like to very much thank the parents and professionals in these 80 countries who completed the questionnaire. We couldn't do this sort of work, obviously, without people taking the time to do that, and would welcome any questions.